Yes.
Okay, well, thank you for all introducing yourselves. This is a different vibe than the other panels. You know, a lot of those folks submitted questions beforehand. This group didn't really do that, but that's okay. So I think whatever you want to talk about, we will do our best to talk about it with you. If there are specific questions, you want to share something. I think I know literally all of you from one point or another, so I've got some background. But yeah, what do you want to talk about?
Well, I can start, and this isn't speaking from I'm not a parent, but I can imagine now there's new care guidelines that have been published, which is very exciting. But help me understand from your perspective the best way to really connect physicians. Everyone's spread out. It's a small cohort. And you know, I just listen to the Ks and the things that they go through. And while we can share that information, it's not always that particular care team has the experience like Dr. Wilson has. And so advice around that, or is there any effort to try to more specifically connect each individual, because it's small, so maybe that's achievable, where we get the care teams of these families really up to the level they need to be providing the best care. Because we might get, like Dr. Wilson's provided care for several patients over the years, but we can't all go to Oregon necessarily to get that real best of the best, I suppose, is a good way to say it.
Yeah, I mean, I think the providers have to kind of be a bit open-minded and have some humility in their care because it's a rare disorder. You're not going to find somebody who's cared for a lot of other patients with PLAN or INAD. I don't think that's necessarily a barrier. I think having the care guidelines is a great starting point, and then they certainly can reach out to us, and we do hear from providers asking questions about caring for patients. There isn't necessarily like a network of providers who care for people with PLAN per se, but I think the care guidelines at least make an effort towards bringing the care up to at least a good level for everybody, and provide people with kind of a starting point. Our emails on there, we have there's a way to reach us from that article. I do that all the time with rare disorders that I've never, it was the first time seeing this, whatever rare disorder it is, which happens a lot to me. And I look up the guideline or the paper or whatever, and I find the author and I send him an email and I say, I have this patient and, these are my questions. That's like a pretty standard thing to do, I think. So yeah, I think just encouraging your providers, saying, hey, this publication came out, just want to share with you. And that's a great starting point, at least.
Could you ever imagine in the future like a round table that's on like a quarterly or I don't know if like there'd be a way to do that a little more formally too, where there's an organized opportunity for those physicians to connect and share stories like we're doing here, but everyone's care team. Just an idea.
Do the child neurologists do that? I mean, do you guys have a listserv or something?
Yeah, I think there are like topics where groups will get together and meet periodically, like movement disorders, for example. There's meetings for physicians across the country sharing cases, basically. And it's a fairly small subset of interests, I think, that garner enough energy and enthusiasm to get a regular kind of conference going. It's certainly possible. I think these things also, they do come up in the meetings where we're at. So our Child Neurology Society meets annually, everybody goes to it, and questions relating to NBIA disorders certainly come up there, and that's like a great spot for lots of physicians who are caring for these people to have a discussion about, but it's a bit ad hoc,
Yeah. I mean, I'll say too, even though PLAN is ultra rare, some of the things that cause you all the most daily challenge, difficulty, whatever, those things aren't necessarily rare, like getting a G-tube or sleep. A lot of these things aren't specific to PLAN, and plenty of child neurologists have experience with those other things, right? So,
Yeah, absolutely. Yeah, I think having a physician who's comfortable just with medical complexity and developmental disabilities in general is what you need. So like I said, nobody out there is going to have a ton of experience, save a handful of people, and doesn't mean you're going to get substandard care. I think people who care for people with developmental disabilities care for all sorts of rare diseases, and that there is a lot of overlap in the needs in those populations.
yeah. Well, and as Jenny said, finding a provider who you're comfortable with, who you can talk to openly, who has, brings some humility to the table, is willing to learn, is willing to reach out to the experts, that's half the battle, in my opinion.
And you would suggest, like definitely a neurologist. Could you maybe describe a care team and the different roles that you think for this particular situation is important to have complementing each other?
Yeah. Yeah, I think a neurologist certainly plays a role and should be kind of a main player throughout the disorder. Somebody who has specialty in development, potentially, it could be the same person, but somebody who can kind of guide developmental evaluations and interventions, that could be like a rehab doctor or developmental specialist, or again, a neurologist who can wear that hat. Rehab specialists, so PTOT speech, obviously, and with feeding specialists, so that it might look different in different places, but somebody to monitor nutrition and feeding safety over time. Usually at some point, like a lung pulmonary specialist might be helpful, depends on the kid, but if they're recurrent respiratory infections, it may be helpful to have that person on board as well. Other players, an ophthalmologist you'll want to see periodically. What am I missing? Might be a GI specialist, but depends on the symptoms, and can your pediatrician manage this, or they've tried everything and we need to go on to a specialist.
We struggled a lot to find a medical home until we got palliative care for comfort, because they can encompass kind of all of that. Like, there's a GI specialist and respiratory, but until we got someone who could manage pain and spasms and all that sort of thing, which was luckily for us all in the palliative care and hospice team, that's been the mainstay of our care, and we felt we've been able to keep her very comfortable.
Mm-hmm. Yeah, that's a great point.
If you don't mind sharing, how often do they come into your home to provide that support?
We have a nurse coming once or twice a week, and we sort of manage the meds, but I'm sure the palliative care doctor would be more involved, would be monitored too.
We see the palliative care doctor maybe like once or twice a year, but the nurse kind of like is the go-between.
I mean, you get so many more services, at least where we are with palliative and hospice.
One thing I'd like to throw in there is that the NBIA Disorders Association has a Center of Excellence program that OHSU is, one of the centers of excellence, but we have a couple others that have all of these specialties and have seen more than one family with one of the NBIA disorders. Not necessarily PLAN or INAD, but they're connected to the network at least, yeah.
Where are the other locations?
We've got CHOP. We just recently got UC Davis, Texas Children, and I think there's one other.
One other I can't think of right now.
Yeah, I can look in my notes. But it's an
Boston?
expanding program. Pennsylvania, yep.
What does it take for a center to be accredited with that? Or
There's a whole list of requirements, yeah, and it's, I was gonna say a sliding scale, but that's not true.
So I'm on that committee, and so there's sort of two different levels. There's like a center of excellence, which means that they're both a clinical center, but also research, and then there's like a clinical center, which is, you know, they have clinical research, clinical experience, but maybe not the research component. And so, you know, it's more that they have like the genetics, neurology, you know, imaging capability, you know, just sort of all of the different pieces clinically that you would need to help give information and manage people with NBIA disorders.
And it's kind of a young program. We've only been doing it for, I think, the last 3 or 4 years. So it's expanding, not where we want it to be yet, but it is getting there.
Okay.
With the UC Davis one, is that, like, how do you go about getting that there? Because we're not terribly far from that area.
How do you get enrolled in seeing them?
Whether it's for research.
Should we just ask our doctor for referrals and just switch over, or is that like, I don't know.
So probably you would contact them,
Yeah.
contact UC Davis, and then they would be the best people to tell you, like, hey, yeah, send over a referral from your, you know, pediatrician, and then they can get you enrolled in their system.
Yeah, and since they're, you know, recently part of this, they really want to have more individuals go out.
Yeah.
So does your committee have the names of those specific clinicians you can?
Yes, let me,
I think
get that
it's,
information for you.
I think it's Dr. Shanker, is that right, at UC Davis?
That sounds familiar.
Yeah.
We're like, I think on Saturday, we're sort of like presenting about, you know, the newest center and.
Okay.
I know she'll be here tomorrow because she's at the clinician training session. So I can put a bug in her ear that there's
We're like
somebody.
in between neurology, because our neurologist, he's awesome, he was like reaching out to researchers all over, and he was, but he's leaving the country, so he's like, and so we're like, we really need a neurologist, like right now. So, we were gonna go to Valley Children's, which is great too, but it'd be better if we could
If there's a
be with
specific.
Yeah.
kind of.
Yeah.
We can certainly get you that.
That'd be awesome, thank you.
This is your time. Other questions? That was kind of awkward, but.
Has anybody had like recent medical issues that they've been dealing with, like G2, that you're either worried about getting or just had recently that you have questions about? Or sleep or seizures or, you
Seizures,
know,
that's a
something.
question. So Lily, our older one, she's 11, almost 12. She is the juvenile version, that would think, right?
Yeah.
So she has these like episodes, and no one can, the doctors, no
Well,
one can really
she's
understand.
wheelchair bound,
Yeah, okay,
not a lot of mobility.
so we've had EEGs done, like multiple ones. Nothing shows up on them as like proper epilepsy, but it is like abnormal. So they're like, it's abnormal, but it's not like the standard epilepsy, you know? And so she has these episodes where she's like kind of staring, but then she also has like anxiety. So there's also times when she's like rocking and breathing really heavy, and she does this like swallow, like I don't know if it's a reflex or what. And so what's tricky is like school gets that confused with like, oh,
She
she's
is
not-
verbal and all.
yeah,
She
she's
has
verbal, but
autistic
school gets that
features.
confused with like, oh, she's having a seizure. And I know they're trying to be super careful, but they count anything as like a seizure, and then they end up wanting to give her Valtoco like all the time. And so then I have to go get her, and I'm like, I don't want to be giving her an emergency medicine if that's not actually what it is. Like if she's just gassy and needs to be vented, you know? But they're not like technically seizures, but they call them seizure-like activity. And so I don't know how to distinguish. I know the doctors have done their very best to like write it out in her medical stuff for school of like, this is what you need to look for, like if she's convulsing, if, you know, but they still like, does that make sense? I don't know if anyone else has dealt with that, where she's like kind of stares off, she's really hard to get her attention. And then after like a minute or two, she comes back and she starts smiling and talking and, yeah.
We're dealing with that with Mila at the moment. Yeah, so she, like, we thought they were perhaps absent seizures.
Yeah.
I used to teach childhood, and that's how I recognised them.
Mhm.
So I spoke to it with, I spoke about it with the paediatrician and the neurologist last week, and they pretty much said we can either do like a sleep study or just put her on medication and see if they stop, which we are a bit hesitant to do because my sister has epilepsy, so like this could also be something genetic.
Right.
So we were told to do something like very uncomfortable to her to try to snap her out of it, and we've been doing it and it doesn't seem to work. So I think we will end up going down that path, but it is a bit of a tricky one because you don't want to give them that unnecessary medication.
Right.
Yeah.
So she's on Epidiolex right now,
Yeah.
which I have noticed it does help reduce the amount of those episodes, but as she's growing, they are starting to increase. And then we've done the sleep study, nothing showed up in the sleep study. And so I guess it's more the confusion of like, it might actually be a seizure, it might actually be absent seizure, but I also feel like sometimes she's just gassy and she's uncomfortable, and so it's hard to distinguish like the difference, or she's just anxious, or,
We also got told like that sometimes children with like similar conditions, because it takes their body so much, like they expend so much energy, it's just them resting.
Right.
Yeah.
That's the other
Yeah.
thought we've had,
And then we're
yeah.
like,
exhausted.
but how do you know?
Yeah, this is like such a common thing that happens, and we're pretty good usually at saying seizure or not seizure. If we certainly if we can catch them on an EEG, usually we can say that. Maybe not 100% of the time, but if it's not a seizure, then we're kind of the reason you don't have an answer is because we don't know we don't really know why kids stare off or have episodes that look like seizures that aren't seizures. It could be a number of reasons, maybe multiple reasons for the same child, and so we don't really have an answer. We can say seizure or not seizure sometimes. On the other hand, like if it's not a seizure, or even if it is a seizure, but it's not too disruptive or bothersome, we're also like, it's probably not hurting them. And big picture, like your medication, potential side effects, all that, versus these episodes, which there's probably aren't doing any harm. Oftentimes it's fine just to watch, even if you're not 100% sure what they are. But it's usually a discussion with your doctor and kind of working on what makes sense for you and for her and all that. But oftentimes just not treating is perfectly reasonable, and just watching and waiting till it declares itself as problematic for doing that. And I hear it sounds like your doctor's doing what they can for the school. I mean, like really. Yeah, just saying like the only time you should give Valtoco is if somebody is having a grand mal or whatever. If they're having a grand mal. And I mean, you could like, there are probably ways to, I don't know, you could meet with, you probably already did, but I don't know, ask for somebody different.
Switching schools, it's really the school that I'm having issues with. The doctors have been great. It's this specific school nurse that's like overly scared.
Because we're already in California, and watching the pattern over time, I think their primary concern with the school nurse and this specific program of school nurses is not getting sued. And so everything ends up being really, really legalistic, as opposed to like, you're a nurse, you're well trained, use your training.
Yeah.
just in that specific
It's
area.
But
So
she's switching, so hopefully
Yeah,
next
but-
year, and we can talk to the doctor and be a little bit more like specific or.
and they are mild. It isn't convulsing. It isn't. And so we've kind of been feeling the same way. It's like we don't want to keep giving medicine for something that may not even exist, let alone possible side effects that could come also. from
Well,
that medicine,
and for
you
the
know.
rescue, I mean, you don't have to have a rescue medicine. Like, you don't have to give the school that option. You can say, if there is a convulsive seizure longer than 5 minutes, call 911. And the seizure rescue medicines are not life-saving in the way that an EpiPen is life-saving.
Okay, that's good to know.
There's data that it like decreases need for a visit to the ER. But especially in that scenario where they're overusing it, you're going to do more harm than good.
And even her pediatrician was like, Valtoco's not going to help cluster seizures anyways, like by the time she comes out of it, So yeah.
Thank you.
Mhm.
Yeah.
Is that a question or a peace sign?
It's a peace sign.
I have a question. I don't know if it's more directed towards the parents, maybe. I have really struggled getting medical professionals to want to help. We do not have a neurologist. The only person that really helps us is our geneticist, which is kind of tied because they've already diagnosed him. We do finally now have a GI doctor that has tremendously helped with his reflux and things that have caused him discomfort, but how did you guys all figure out to cordially find a doctor that's willing to help? Because I mean, like I said, he does have an ophthalmologist, because that's how we first found out that there were issues, was his PT, speech, and OT saw the nystagmus. And he then referenced us for a brain MRI, which came back normal at the time, because that was probably 8 months before we got the diagnosis. And I will not go back to that neurologist. So that's been our biggest struggle, is just getting someone that is willing to step along with me during this journey to want to help, because it's not fun. No parent wants to be in this, but you've got to find someone that's willing to. I mean, not every doctor is going to win every single time. You've got to be willing to fail to figure out the rarity of it. That's my biggest struggle.
We've had them struggle heaps. Like we've been with AIDS for 5 months since our diagnosis, and it's been horrible. I've just been really brutal. And I just said, this is the team, this is what we need from you. If you don't want to be on it, tell me now, don't string us along. And I've been able to bleed out really quick. And then when I contact a doctor, I'll say, this is what I need, can you give that to me? Yes or no?
So you call and then ask if, do you ever go in and meet with them person to person to?
Yeah.
Okay.
Yeah. And I've done that with speech pathologist, like we have a speech pathologist who was great, but then she just wasn't meeting the other needs. It kind of got to a point, it was like awkward. I could tell she didn't know what to do, but she didn't want to tell me that. And I just said to her, I can tell this is happening, and that's fine. You don't need to go to the but you don't want to. So I reached out to about 5 other therapists, and you get a feel, you meet with them, and I was just really open with, this is what we need, can you give it to us or not? And yeah, we've been able to find decent help on our team, and we're having the same with our neurologist. I directed her a lot. I got told I was the expert, and I said, well, I'm not, like, you're the medical professional, I'm not the expert. That's a cop-out. And yeah, it's really hard because you don't want to be like that, but who wants to be that confrontational all the time, especially when you're dealing with the emotional toll. But I found it's worked, and I also find when you find one good specialist, they usually know.
That's what
Good
has helped
specialist.
me.
That's true.
Yeah.
Our geneticist has been the biggest lifesaver
Yeah.
for us, but like I said, our hands are tied, so it's just like passing off to people that can help.
Yeah.
Do you have a good general pediatrician?
No.
Or,
I'm about to be on a third.
Do you have a good
yeah.
physio? Because we found out physio was really good in knowing.
I don't have one.
PT. PT.
Oh, yes.
Physio is
yes.
PT.
Yeah. Yes, our PT has been absolutely amazing.
Because that's who got us onto our neurologist.
See, and we go to a PT that is not hospital associated. So she reaches out to people that she knows, but she kind of, again, is kind of on the outside. So it's not, she doesn't know many hospital affiliations from a doctor perspective.
Yeah.
Is there a complex care pediatrician in your area?
Not that I have found. I got told I was absolutely nuts by our first pediatrician, and one of these days, will walk my happy little butt in there and say, I'm not nuts, but I've got to wait till my
Is there a
Angry
children's
side.
hospital around you guys? So
There
do they have a
is,
complex
yeah.
care? Because that's where we.
Indianapolis,
Because our
I guess
geneticist
Riley
was the one who
Children's,
was-
right?
We had a great pediatrician, but he was like, I don't know what to do with this.
He
Like,
was
I don't.
humble. He was humble.
He was
enough
humble
to
enough to
say,
be like,
Yeah.
yes, but
I
then,
don't
but then the
know.
geneticist was like, you need to go to complex care, and then from there, they were the ones who were like, okay, let's get get you?
We have a developmental pediatrician, but he is retiring and he doesn't want us to stay within that office. So that's kind of, he's been wonderful. He's the one that got us into the hospital to get all of the, he originally thought it was cancer that started all of it. So we were in the hospital for several days getting tests, but with him retiring is where I'm like, I need someone else that's gonna be able to help because the pediatrician is so hands-off.
You could look at United Cerebral Palsy Foundation. So I'm just thinking like a big group that is going to have similar needs. So UCP, there's usually a local chapter with community boards and things like that, and somebody who can give you resources. And they're going to be also needing complex care physicians, same needs. So that might be another resource just to get some good names.
You're in Indianapolis?
Yeah.
Do you know the Bannock's?
Carolyn, yes.
Okay.
Yeah, I text her quite frequently, actually. Yeah, she, who I've been looking for, has not been one that she jumps on referring me to, which is my hesitancy switching to that. We did get a name from the geneticist that is, he's a neurologist that specializes in muscular dystrophy too, so we're trying to get in that. That was just recently that we were told that, so.
I mean, so clinical geneticist can be the quarterback for you. I mean, the neurologist is typically the one, but a geneticist, it's not unusual at all to see your clinical geneticist once a year and have them kind of check in and be like, what's happening with vision, what's happening with neurology, what's happening with feeding. Like, they can do that. But I kind of like the palliative care idea. Like, if you have a children's hospital there, right? Is it Riley? I'm trying to remember.
Riley,
So they should have palliative, like a palliative care.
So
They
we
seem to
have,
be the only ones who aren't afraid of these.
Right.
things. Honestly, I mean, as a doctor, sometimes it's like, I don't know what am I supposed to do for this? I can treat maybe seizures, but that's it. I don't know another treatment, but palliative care really like takes the whole holistic.
maybe I need to be more assertive there because we have them.
Mm-hmm.
We have only seen them via Teams.
Okay.
We
So
have never been in person with
maybe it's time to
everybody
go.
there. Yeah, and I think they felt my frustration on that the last call, so hopefully we can, I just need to be more like, no, you need to see us in person to help us get.
It's going to be a bit variable. I mean, I think there are a lot of different services, a lot more services offered if you do hospice than if you're just consulting with the palliative care team. So they may or may not, prescribe medications and do symptomatic care. They might not. Hospice is like ups your level considerably, where you get in-home help and there's a physician prescribing medications in that scenario. And so I think it's a great avenue to investigate. And there's going to be different levels of support you get depending on kind of which direction you go.
Right, okay.
And Cidra's been on hospice for 3 years, so it's not like
Right.
Yeah,
the qualification is that you wouldn't be sick, if that's the right word, if this person passed within 6 months, which is not necessarily the case for our kids, but not impossible. So then that way, we qualified and got so much support. Like, we don't even take pictures.
They look at diapers, like having a nurse twice a week to like come in and check on her when she's sick is like great.
We're getting
We just
nebulizers
started
and-
palliative care for our girls, and they're still doing well, considering, but it's in conjunction. They don't get to, they still see all the specialists, they still get to do all the therapies. They're just like an extra support, and they have like a person that comes in and is like, what do you need? Are you struggling with it? And they will go and like help us find what we need.
Also, in like just finding other people and other services. So I mean, if you have something like that, when you get started, that might also help in connecting with other doctors that will help.
Another thing, so I just looked real quick, is physical medicine rehab with physiatry. So I'm a physiatrist. I'm an adult physiatrist. Yeah, but they can help a lot with equipment, bracing. They'll help with spasticity management. Probably not so much with seizures or things like that, but like they can also help connect you with people.
policies are different from state to state and country to country, obviously. So I don't know how it's going to work there. Our experience with our palliative care group hasn't been so great, but we do have a fantastic primary care physician. So that's, once you find somebody who can be like on your team, it helps to get other people on there as well.
And obviously, all the doctors are great. It's just finding the ones that are willing.
Take ownership.
To want to, I don't know, fail. You know what I mean? Because that's so hard for anybody to be like, I don't know what to do. But
I feel like a lot, like there's not been any of them that have taken the self-initiative to reach out for help. It's just, oh, this is what I don't know, but try this, instead of reaching out to you or, the Center of Excellence down there, just researching it themselves, where Dr. Conboy, the geneticist, is the only one that has taken some initiative on that, so.
Well,
I mean, as parents, it's so hard because you research and do everything you can because it's your child, and it's like, that's what you went to school for. I just want help.
yeah. Well, I have a clear bias when I say this, but sometimes an academic medical center is the place where you're more likely to find somebody who's interested in learning.
Which we really should be at,
places where
Riley,
it's
because it's
only
so
visit,
good to IU.
and they just can't.
Yeah.
They can't research. They
Yes.
don't have time. It's a sad part of the medical system.
I can't remember if there's a Shriners in Indianapolis.
There is a big one.
And it's orthopedic. Because that would be another place.
Yeah.
Well, a hospital, though, you mean, Shriners Hospital?
Yeah.
I don't know if there's a big support of Shriners. I
Hmm.
don't think there's a hospital.
I'll look tonight. I can't remember if I ever checked.
Have any others had issues with reflux?
Yeah, I didn't, like, with the GI, I thought she was having, because she'll say, like, I'm throwing up, But then we tried all the things, and, like, it wasn't changing. So then the doctor was like, I think it's just like a
tick almost.
yeah, like she'll do this,
Or
like swallowing, burping thing. And I don't know if she's actually refluxing, And so it was kind of silly to keep her on medicine for something that's not actually happening.
So he had what I thought was reflux, like since he got his G-tube.
Yeah.
And we saw a GI doctor in February and put him on ciprofloxacin. I think that's the correct name. But he said what happens with a lot of GI patients, and I'm just bringing this up because it helped us tremendously. The G-tube placement kind of hinders that side of their stomach, so it can't expand and then go like this as it should. It's just kind of half on that side. So then they can't take the full volume that they want, so then the food is kind of coming back up and then back down, so it's not technically reflux. And this medicine has made a world of a difference for him. And he,
Make it
like you were
empty
talking about
faster.
that swallowing, he will play with his mouth, and so then I'm like, okay, it's time to do that for like 3 to 4 days, and then we take a couple days off, and then we do it another. But it has helped. So he used to get sick almost daily from his G-tube.
Like throwing up.
Mhm.
Yeah, because I didn't know what it was, because I'm like, she's not having reflux, but she keeps doing it. So then I know she ends up swallowing air, so then I'm usually like, okay, we need to vent her, because she's swallowing a bunch of air, and so, which helps, I guess, relieve the discomfort, but like, all the reflux medicine didn't change the amount, how much she was doing it,
What was the name of that again?
It's ciproheptadine, right?
Yeah.
S or
What does
C?
it do?
C.
Yeah, it's an antihistamine. It's also called periactin. We use it for a lot of different things. So we use it for migraines and for sleep, maybe a little for anxiety and allergies. And the GI docs use it to help with motility. Like kids who gag a lot tends to be helpful for them. I'm not really sure exactly why, but
What does it do?
yeah, it's an antihistamine. That's all I can tell you. Yeah, I don't know.
They use it as an appetite stimulant,
Oh,
I
yes,
know,
and
in
that.
kids with ADHD.
Oh, okay.
Boston to the like aerodigestic expert in the world, Dr. Rosen, because we were ready, like, we were ready to stop feeds and let her go. It was going so bad. But the real food, the weight of it has helped in them switching instead of water to applesauce. So there's more weight and it
It's kinda like
stays
stays
down. As now she's 5 instead of 2, which is when we thought.
Yeah.
We have those milk foods too.
So that seems to have helped.
Animal integrity, dairy suppositories, promoting.
A lot of stuff to just kind of keep things moving at the other end.
What is your guys', because like, Lily got her G2 when she was 8, and she's almost 12, and we've just been on Cape Farms, like, the whole time, and I've asked about, like, blended, and at least where we're at, they tend to be like, well, this is fine, like, she's doing good, this is really good stuff, and I'm not, like, against it. I know Cape Farms is made with good things, but, like, I just feel like the same thing for your whole life, I don't know, like, I don't know how good that is for you,
I don't know that she can taste it, but like, there's like eggs, there's a beef-based one, there's hemp and kale cheese, much better than all of them. Her hair is beautiful.
It's called Real Foods.
Real foods, and they come in pouches, because I would lose
Well,
my
because I know
mind if
insurance
tried to
doesn't
blend.
cover both, like, it's like one or the other, but
Yeah,
like,
it's
how
supposed
does that, I mean, I guess from like a doctor too, like, what is your guys' opinion? Or like, is it case to case, or, you know?
Yeah, I mean, I don't delve deep in the nutrition and the formulas, but I mean, I have heard that like in general, whole food blends, which includes like Cape Farms, like as opposed to the hydrolyzed whatever, a lot of kids do way better on them, but like one versus the other. I mean, I don't see why you couldn't try a different one. That seems like, why not? But from my standpoint, I don't have like a specific recommendation.
So you can buy it on Amazon, like you buy a 12 pack, it's like $65 for a 12 pack, but
And is it like a, like full, like if that's all she had, that's like all her nutrition will need, like it needs all of the vitamins and everything?
so we give her like a multivitamin,
Some salt.
some salt, calcium. So it doesn't really have, there's some things that it lacks.
Yeah.
So definitely I would talk to a nutritionist
That's
if you're
good.
gonna switch. But, yeah, I mean, most of it.
But you said it's helped her from the like, weight loss stuff. Yeah.
Usually, like, it was like multiple times a day that she was throwing up. And now she still does sometimes, but it's a lot less frequently.
Ours helped, we have the same thing, but we have an organic kind because of his allergies. We couldn't do Cape Farms because he's allergic to like pea protein and dairy and all that, so. Yeah, but that helped too. The thickness of it is what helps it sit better in the stomach.
Thank you.
Can I ask, at what point did you guys know it was time for a G-tube? Because I just had the name of the pediatrician and she goes, I want to put you on the wait list because the wait list is quite long at our children's hospital. She goes, and most parents don't go on the wait list when they need it. And she goes, Mila doesn't need it now, but I want you to be on there, so when she does need it, you're ahead. And she goes, when it comes to that time, it's up to like myself and Andrew. And I was like, but we don't know. Like, how do we know? Like, at the moment, she's eating normally. So how did you know it was like that was coming? Because at the moment, like, our issue with her swallowing is she'll like spit out water, but she's still getting a lot of water as well. And she also laughs about it. So like, are you also? Or like, are you just naughty? Because yeah, she's still getting that hydration. She's still getting wet nappies, passing quite well. But yeah, like, how did you? If it's going to be our decision, we obviously need to know now. When do you make the call?
From Warner's perspective, he was still eating everything, and I was very much in denial about getting on YouTube. Like, I did not want, because I was like, that's the next step. I'm not ready for that. But he was choking pretty frequently when eating. Not that he couldn't eat, his muscle tone is so low that it was just sitting in there. He wasn't chewing it very well, so then he would choke on it, and it got to the point where I was like, okay, we can't do this anymore, because he would go limp and just completely ghost white. And so I wish I would have done it sooner because it made a world of a difference from his, like, he just seemed so much happier. And not that he wasn't happy before, he's always been smiley and everything like that, but I think it was me that held him back not knowing. You know what I mean? But I don't know that there's ever really a right time.
Okay. Yeah.
Just
So-
when-
That's good to know.
I think a cheat tube doesn't mean that someone can't still eat by mouth, right? I think for Sage, she was like the 0.1 percentile. Like, she was just super, super, super small. It took an hour to really like give her any food, and she just wasn't growing. And so for us, it was like, yeah, we gotta do that. But like, people can still eat and drink, and it just allows them to get enough nutrition to keep growing.
So same with Lily, so we were also, it was all like a whirlwind, like we got the diagnosis and like everything, it was like everything.
We got it pretty late. She was
Yeah.
8 or 7. Yeah.
Or 7, but I could not get her to eat, like she just slowly over the year, like stopped, like she was still eating and snacking, but I just could, like, it got to the point where she ended up needing dental surgery, like we wanted to put her under for surgery, which was probably like the worst decision ever, because they did so much to her mouth, and then a month later, I was lucky to get her to eat a cracker in a day, like she just stopped eating, and when she turned 8, then she dropped down to like the 3rd percentile, and she stopped growing. So she was like the height and the size of a 5-year-old, but she was 8, and it became an emergency. Like they had been telling us about it, and we were both thinking into that, like, oh, that's such a big. But I wish we would have done it sooner because we didn't realize how malnourished she was. Like every day I was trying so hard to get her to eat and drink, and it was very little. And then when we got the G2, I was like, oh my gosh, she's like, the color's back. She's a little bit more energetic, like, and she's still tired and fatigued, but it was just, literally saved her life from starving to death.
She
Like, I
jumped
didn't
up
realize.
50% in weight, like,
Yeah, so
in 6
fast.
months. And like her skin color literally changed. We
Like,
didn't
she
realize
was
it was
so
off, like
pale.
actually changed. It was, yeah, but we waited too long.
But even
we
now,
didn't know.
like, I suppose she still eats peanut butter crackers, and she never
Yeah.
really chokes. That's the thing, like, she wasn't choking. Like, sometimes she'll kind of choke on water now, but like, she can still eat and drink, but that's her main source of nutrition. Like, she would not be able to eat to sustain herself anymore. So it was such a relief, not realizing, and fighting to give her meds orally was like an hour long every day just to get her to take her medication. And now she's like, yeah, put it in my tube. You like, you know,
Too
so
deep.
that's why, you know, so it's way easier for all of
Yeah,
us.
and like
Yeah.
you were saying, it's so much less invasive than I imagined.
Yeah,
it.
yeah.
And like,
It's
you can just
not.
do everything completely normal. And if they're eating well,
Yeah.
don't use it. Like
Yeah.
it's, yeah, so if you're already on a wait list,
Yeah.
that seems wise.
And if you get one, it's not a failure
Mm-mm.
of you as a parent, because I just felt like, well, I'm not getting him the food that he, you know what I mean? Like, it'll make you guys so much easier.
Yeah,
with
because like we don't
things.
care to get it, but like when it's put on you, like, yeah, it'll be your decision.
Yeah.
And it's technically an elective surgery still, which
Yeah.
seems crazy because it's like literally saved her life. Like she wouldn't be
Yeah.
alive.
And that's what I
without
thought. I
it.
was like, well, isn't it to sustain them?
Yeah.
It is, and if she were to start losing weight, like
Yeah.
Warner became where he needed to be weight-wise, and he was burning more calories than he was taking in because to eat.
Yes, yes.
So then, it made a big difference
Yeah.
on him once they made that decision.
Yeah.
It's- yeah.
I was gonna, unless there's more GI stuff, I was gonna ask about early puberty, if anyone else is dealing with that, because we started, Sage is 5, and we upped her G2 feed, she gained some weight, and now, we're waiting to get into the endocrinologist. She's like growing breast buds and, getting hair, she's smelly. But I don't know if anyone else has, like, I just haven't used puberty blockers before or anything like that. I don't know if anyone else has experience with it.
Lily started her cycle, I mean, she's 11, but she started in November of last year. To me, it seemed, I know it's not technically early, and she's the juvenile version. I know there's the babies who like start earlier, but she seemed like she developed like that. Like she's already developing that, like, started all that, like, we chose not to do anything. The only thing is having more of these like episodes around puberty, then like it's a conversation. But we haven't really seen it. And just, I mean, it's not, it doesn't seem to be bothering her. So as long as it's not like, I just hate to put more like medication in a child who's already taken a lot of medication or something. As long as it's not bothering her.
Because we haven't noticed any negative effects at this point for her.
Yeah.
But she's not
Because
five.
she's not-
Yeah,
So I
that's
don't
a big
know.
difference, yeah.
She's 5.
Yeah, that's different. I don't know.
Definitely talk with the endocrinologist. I mean, I think there's a choice. Like many parents will do puberty blockers, but you don't have to. She won't grow as tall if she goes through puberty, but that may not be a bad thing. Some people actually,
It's all comfort.
yeah. So some people actually induce puberty early in kids if they don't want them to grow too tall. That's rare, but in kids where they're going to be, their parents are going to be caring for them, someone else is going to be caring for them. So, maybe just fine to let her progress. But total conversation with endocrinologist. I don't know, have you heard of it in the database?
I was going to say, I haven't.
I've
I
seen
mean-
it in the INAD community. That
Okay.
Several parents have said, around 4.
That's really interesting, because in BPAN, we picked up on that pretty quick. All the families here with BPAN, we see premature adrenarche. So they don't actually menstruate early, but they get stinky pits and pubic hair. And,
Yeah, she's
Yeah.
gone through adrenarche. but-
yeah. But I haven't heard it as for INAD. The BPAN parents, I can tell you, generally don't do much about it. Well, yeah, I mean, that's a different conversation too, I think, like the BPAN, I'm saying BPAN because there's such a large number of them here compared to anybody else, and because they have issues with this, but a lot of them who are old enough to be menstruating just don't. They're on injection, IUD, birth control pills, whatever it is, they just don't menstruate. Hi, buddy. You hungry?
What is your guys', have any of you done Botox or muscle plasticity? Because we're at that crux of the conversation where we've been doing baclofen, but both of our girls, especially Lily, she's a little bit farther progressed, is getting super duper stiff, and she wakes up every day in the fetal position, super tight, and then throughout the day she's really tight, and so it's the thing that the physiatrist was he's new. Our physiatrist just came to Valley Children's, and so he's like I would like to know what the PT says, because she's been working with her a little more, and our PT's on maternity leave. So I was just trying to ask other people what is your experience with Botox? If you've done Botox, if you haven't, I don't know. Does it help? Does it help? Does it not help?
They're
Is it risky?
exploring it with Mila, so that's something they're referring her to the rehab team at our children's hospital to explore. So the only concern they have with giving Mila Botox, because she's got really tight knuckles, so that's why they want to give it to her. But their concern is because she's got low muscle tone, that it can kind of make that lower, so it can have.
Right, that's what he's worked on.
Yeah, so they're just going to explore it and then kind of pinpoint the time where we actually intervene.
Yeah, I haven't used it in kids with PLAN or INAD. I think, there's a fair amount of cautions around it, and you want to have, if you're going to do it, very clear goals that are worth it, essentially, because there are often other approaches to achieving some goals. Like if the ankles are tight, sometimes they do serial casting, or there may be other options. And ideally the Botox stays in the muscle it's injected into, but there is a small chance of having the Botox kind of leak out into the bloodstream and cause weakness everywhere. And that risk is higher in kids who already have baseline issues with weakness or respiratory difficulties or swallowing difficulties. And because we've done this quite a bit in children with cerebral palsy, and if they are more severely impacted with those issues, they have a higher risk of having that systemic effect, which is scary. It's still rare, but it's, a scary possibility. So yeah, I think word of caution with it, and if you're going to do it, there should be really goals that are worthy of doing it.
Can I ask with that, so you mentioned the serial casting, because that's something, when this got brought up by the pediatrician to refer to the rehab for potential Botox, our physio was like, I think they should try serial casting first. She used to work out at Great Ormond Street in London, and she was saying there's different techniques for serial casting. Is there a preferred technique with children?
No, I think it's oftentimes physios have their own experience and prefer what they're good at, essentially, or how they trained, and they'll use whatever technique that is, and that's probably fine. I don't know that there are great studies on a preferred technique for serial casting. So basically, it's when we use it for kids when they have ankle contractures, so when they can't get their ankle to 90 degrees. And oftentimes, the challenges with that is if you want them to be weight bearing, if they're standing, they can't wear a brace, and it's really hard to stand if your ankle doesn't get to 90 degrees. Now, some kids, it's like maybe that's not a goal anymore. We like weight bearing because it builds bone density and helps digestion and probably opens up the airways a little bit and things like that. But for some kids, maybe it's not a goal, and then it's okay if their ankles don't get to 90. But if that is a goal and the ankles get kind of stuck, the only way to fix a contracture is either by serial casting or surgery, really. And serial casting, they put a hard cast on, basically from below the knee, like you broke your ankle, all the way down, and they kind of hold the ankle there for 7 to 10 days. Then they take it off, push the ankle a little bit further, put a cast on, so I'm going to take it off, push it a little further until you get to your 90 degrees. Yeah.
We had the surgery for that, and it worked fine. We still get her in her stander once a day with braces on. Yeah, it's good to have the weight bearing.
Yeah.
Do you guys do PT and all of that more than once a week?
Our PT, I don't know if we should be fighting for more, but I think because of their condition, they're like, well, we're just trying to maintain now, so they do once a month. And I don't know if that's not enough, or, because they're like, well, the idea is that we'll do it and then we give you homework to do at home. And we have a goal of with the standard of how long we should be having her in it every day and stuff like that. But it's the same thing with OT. Now, actually, I think Lily, she just had her eval. One of them, I don't remember if it's PT or OT. It's now once every other month, which doesn't seem like very much. But they are also getting it at school a little bit too. Yeah.
We do our physio weekly, but it alternates between, the first day comes out, so on land, and then the next one's hydro. So and hydro's really helps one. I would say hydro is the best therapy that we do with them. Just with digestion, just movement, enjoyment as well. Yeah, loves it. And then we do our OT fortnightly as well. And then our speech is not monthly. But we've got the capacity to do it every fortnight as well. And OT, they've offered us weekly, but we just can't fit it in.
Yeah.
It's just, there's no time.
We do PT once a week, and we love the pool PT. That was perfect. It's kind of harder to assess how much she's enjoying it, because she's much more withdrawn now. But really hard. But we insist on once a week PT. Just to make sure that she gets it through the school year.
OT. OT and PT.
Yeah, I think it's hard to get much more than that, except for on a
I just didn't know
occasional
what the-
basis. Yeah.
What it should be or the normal should be, I was like, surely that's good.
Yeah, no, I think that's great, and kind of depends on the person and the goals and how much they're getting out of it and how much time you have and all that stuff. And some people will do like intensives occasionally where they're doing a lot more. I think but once a week is a fantastic amount of therapies. Not many people would get more than that for each therapy.
We also found, this is outside of like medical stuff, but there's a place near us that does like equine therapy, so they ride horses, and that really like relaxes her legs because of the warmth of the horse and like the way it moves. That's just like an extra thing that like our regional center helps pay for, and they really enjoy it. It's kind of like their like fun thing they do because they don't get PT every week. So that's good. And he specializes in like complex kids, so he only takes medical complex kids. It's not just for like anybody. And he has like a lot of people there helping and stuff. But I know not everywhere has that.
I was wondering, like, recreational, so like that fun, there's not much in Melbourne. And like, I don't mind driving, but like the closest one to us is about an hour and a half drive. And it's just children with like abilities, which is totally fine. But yeah, like, what's available to you guys? Like, do you do anything for them to socialize? Because like, I'm at the point where I'm actually thinking of starting something myself and reaching out to physiotherapists and saying like, do you have any kids? Like, tell them to come and like a play group kind of thing.
Yeah.
Because like they were like, take her to the play group. She was sitting there and these kids are running around. And I was like, just get a tramp. This is ridiculous. She's getting nothing out of it. And then like I had to bring my other daughter. She's running around and I'm like, oh my gosh,
Yeah.
this is not fun.
For us,
Yeah.
we're really blessed in that, like, our church, when we settled in our church, we didn't know any of the diagnosis or anything. And then all these diagnoses came for our kids later, but they just, happened to be a lot of foster adoption, and then within that realm, a lot of special needs. And there's also biological family that also has special needs. And so I think Lily in particular, because they'll have like a one-on-one helper that volunteers, and so she feels very much like a part of that, because the kids are crazy and running around, but I think because it's such a part of the culture, they'll go interact with her, because it's like with Lily and really with Honora, our other, she's 7, but if the person interacting is not intentionally interacting with them, it doesn't work both ways. Like if it's a normal interaction, they're gonna walk away. And so I think we're very blessed in that sense, that there is like a strong community, not just for us as parents, but for her specifically. But that, in our area, that's super rare even within churches. Like we just happen to end up there, I don't know if there's anything else.
No, well, it allows her, and then with school too, like we had to really push for like a one-on-one aid, because there's some kids who are really sweet who will come up and talk, but a lot of kids, I think they just don't know how to interact. Even adults don't know how to, like, they'll like talk to us instead of, and like kids will be like, why doesn't she walk, or what's her name? I'm like, ask her. Like, like you can talk to her, like even if she doesn't talk back, like you can still talk to her. And a lot of it is just like teaching other people around you, like, there's still people, they can hear you, they want to be social. But it's allowed her to like be a part of the other kids because there's somebody there, and then I don't have to worry as a parent, like, is she being ignored? Is she just crying in the corner? That would happen a lot. Like in kindergarten, her teacher, like before we knew it, she'd just stick her in the corner because she was crying and she didn't know how to deal with her, so she'd just be like, go cry over there, and I'm like,
for a whole
that's
semester.
not okay, just awful. But it's taken a lot of years to like figure out what she needs and how, you just have to like keep fighting. But finding groups with other, even if it's like moms with or parents of kids with autism, like even though if it's not, they're not diagnosed with autism, it's at least there's an understanding of like, this is hard and like we get it,
We have that in Melbourne, but they seem to be like very behavioural, where it's like challenging behaviours, and I don't think that would have it's like, okay, now this is safety.
Yeah, that's real.
So yeah, it seems to be more targeted towards challenging behaviour rather than like regularity.
Yeah.
just all communication.
Yeah.
Yeah. So yeah, I think, yeah, I actually was speaking to Andrew last night, and I think I'm just going to do it, because if so, like someone has to do it.
There's probably so many other people that are feeling just like you, that if you do that, like,
Yeah, absolutely. So, but it's interesting how it's not like an isolated issue to like a place, it's everywhere.
yeah.
And like you think, yeah, it's a rare disease, but we're all from different places and it's like real. And there's other people who might not be this diagnosis, but have similarly. And it's just a need that's not met. Like there's still people,
Right.
there's still children, like they need the same things that we all need.
I don't know about like in Australia, but for me growing up, like even going through like grade school, high school, like anybody with special needs was so isolated, even at school. It's
You
like,
take it out of the classroom.
I never learned how to interact with them. And then you don't want to like ask the wrong thing, so you just end up not ever interacting with them. And then that carries on to adulthood, and then your children learn that from you, even though children naturally just want to go up and talk, you know?
See, it's changing in Australia now. Like it used to be like that growing up, but like now, because I'm a teacher, everyone's integrated.
That's so
And the
good.
kids are so good. Like you just,
So
you
good.
look at these 7-year-olds who have more compassion than the
Yeah.
average adult. And you're like, wow, you just diffused this child by yourself and I didn't even have to step in. Like you just knew what to do. Like, you're awesome. Or just like including kids with mobility issues
Yeah.
and just modifying their games with no second thought.
Yeah.
So it's getting better.
Yeah.
But there's still a way to go.
How does everyone go with their child and sleeping? Mila sleeps for 12 hours, 12 to 14 hours a night, which she's obviously using a lot of energy, as well as particularly at her age. But as they get older as well, sleep is still what they sleep long, they don't sleep much at all.
With both of our girls, they went through a phase of we struggled with the sleep, like around the same time, age 3, 4. We just get up multiple times. But I think working with doctors and specialists, medications and stuff have helped with them sleeping through the night. And then just in general, and again, I don't know if it's because of the disease or if it's side effects of medication, they are just fatigued during the day. I just think too, their bodies are working extra hard to just maintain and be awake. But because we are on like low doses of baclofen, and then we do give a little bit of THC to both of the girls for like nerve pain and stiffness and all that at night. That all kind of helps with them sleeping through the night. And then Honora gets CBN, which is like the sleeping part of the THC. It's not the like hallucinative, but that because she was really struggling with staying asleep. Even right now, like she's struggling to go to bed. Like we put her to bed at around 7:30, and she's still awake at like 11 p.m. just like
But
chatting and
she's
talking.
exhausted going to bed.
And then it cycles of like, because they're not getting enough sleep, then they like, she loses her ever-loving mind every single day. She like hits and all the things because she's so perpetually exhausted all the time. So it's a challenge, and I think they go through like seasons of like, oh, we're good, and then something else changes, and then that probably doesn't answer your question at all. I'm
That's
sorry.
our experience,
Just telling you.
yeah.
Yeah.
Because yeah, we're kind of going through this stage, which like my eldest daughter, she dropped her nap at 2, like she's wild, but now she kind of, like she's sleeping so well at night, and she wants to drop her nap, but she's fatiguing, and we're like, but you can't drop your nap because they're,
Yeah.
yeah, you don't have the energy, and it's like, so do we wake her up earlier, but then she just is tired all day?
Particularly with the appointments as well, right?
Yeah, because then we're like, we've actually got, like, we've got to do stuff. We've got to like maintain you as well, and but then yeah, she wants to stay up all day. Yeah,
How old
it's-
is she?
She's 2.5.
Oh.
Yeah.
I mean, I made my typical kids take naps. I was like, you're sleeping as long as possible. I need the nap for my mental
So like
state,
4
but-
or 5,
Yeah,
right?
I know,
Then, yeah.
Yeah, eldest just
Preschool.
refused. Like, it's true, and I was like, no, I'm with you all day. I was like, yeah, cool. So I was like, are you just like, oh, is this part of, I don't know. I just don't know. But yeah, and then even the thing is like, you should try to maintain the naps, but I'm like, but she won't sleep.
Oh.
Like, what's it saying?
So I had to stop his naps because he would not sleep at night. And even though he was a little more tired throughout the day in different like mentally struggling during all of this, getting no sleep is not helpful. So that's just what we did, is we stopped the nap. Now, there are occasional times, like we're traveling and stuff like that, that he'll still nap, but I try not to, because he does sleep so much better.
Okay, that's good to know.
And he sleeps right around 10 to 11 hours a night.
Yeah. Okay. That's good to know. See, I was like, am I doing something wrong? Like,
Nope.
no.
You are not.
Some kids just need a lot of sleep. And there's a broad spectrum of, and kids usually will get what they need. You know what I mean? Like, yeah. I mean, if there's like a big change, then might be worth investigating. But I think that seems like a reasonable amount of sleep for her. Yeah.
Today she'll be horrible because we're not letting her sleep. I was like, we cannot do what we did last night again.
You've asked a lot of everybody's circadian rhythms coming here.
No kidding.
She didn't sleep at all on the flight over, like it was 16
Oh,
hours
wow.
to Dallas, and she did not have a wink of sleep. I stayed standing for about 4 hours on the flight.
Oh my gosh.
From your two perspectives, is there any advice that you guys have to a parent in this situation? If they feel like they're struggling or anything, like just medical advice?
I would say you're already doing one of the best things you can do, which is talking to each other. I mean, that's huge. You are not going to find anybody else who understands like you are in this room. You know that. I hope you would look to us, to our team. You know, we're partners in this with you in many ways now. You know, because sometimes I can say, yeah, I talked to somebody 2 years ago who had that same problem. Yes, sometimes. And with the guideline, I think everything's pretty fresh right now in terms of we've been thinking about all of it. I think trust your gut. That's the other thing. You know your kids better than anybody else.
Yeah, take care of yourselves and give yourselves grace as you're going through all this. I think parents take on a lot of guilt and worry about whether they're doing everything the way they should be doing it, and you probably are. So, yeah.
Psychiatrist, this is one of the most intense experiences I can think of that a human being, especially a parent, can go through. It's like, honestly, I think it is. And being working trauma, as well. Symptoms, I think, if you're struggling mentally, then like reaching out to get a therapist who you trust and like can talk to about the general issues of being isolated often and struggling with a very ill or terminally ill kid, using all the mental health tools that you're comfortable using. That would be to get professional help as well.
Yeah, we've got 11 minutes and 9 seconds.
It didn't cross my mind until we were like on our way here and we stopped with the dad of the little girl, and he was mentioning like that he mainly goes to Oregon for a lot of the stuff, and then his like team of doctors kind of take your guys' lead. Is that something that you guys do with a lot of like NBIA people affected with it, or?
I think this is a girl with pecan.
Oh.
Is she 12 or 13?
Yes, I'm sorry.
I know
we
you're not.
went to
It just
our
clicked.
little tram.
Yeah.
And I got confused, I'm sorry.
So, I mean, Jenny can answer this too, but no. I mean, honestly, we don't have the capacity for everybody to come
Of
see us
course,
once
yeah.
a year. They are a special case, and they really like to do that, and it's like a road trip, and
Yeah.
it's just all happy and good.
Okay.
But we are available for that. Like anybody who comes to see us in clinic, once we have seen you in person, we know your kids, we've laid hands on them, seen their records, then it is a lot easier to consult with your local doctors. Hopefully your local doctors are open to that or feel more comfortable with it because it's a shared patient now. But you don't have to come to Oregon to get that. We do it all the time too with people who haven't come.
Yeah.
But yeah, we do have a clinic where we see kids with NBIA disorders from all
All of
over
them.
who
Yeah.
want to come. So, yeah.
And then is it like a consultation then with their doctors and stuff?
So it's usually like a 2.5 hour appointment with Jenny and Susan Hayflick and sometimes Dr. Hogarth, who's our movement disorders adult person. And, you know, we spend a lot of time going through history, doing a physical exam, neuro exam, developmental stuff. Time for as many questions as somebody wants to ask, and they usually bring a list. We do some video recording. We try to put in a research component. But no, we cannot prescribe, you know, the state laws and all these things. We can't be like the main provider, the prescriber. But what we can do is write a detailed note back saying, you know, we saw Honora or Liliana, and we, you know, noticed these things and this drug might help. You know, we can sometimes suggest things that haven't been tried yet or a different kind of brace or, you know, whatever it is.
Yeah. And is that usually, does insurance cover that or is that paid out of pocket or how does that?
It depends on the insurance.
Okay.
Like Medicaid, no, that's usually by state and they don't, like, you
Right.
can try to make a case for getting something out of state, but I haven't seen it work yet. Most other insurances have been pretty good. If it were out of pocket, I think it comes out to the neighborhood of like $600. We're not ordering labs, we're not doing MRIs, it's just to sit in the room that we provide and talk to us. Yeah.
Okay.
So that's, you know, like there's a facility fee and a doctor fee.
Of course, yeah. Okay. Thank you.
I think the Centers of Excellence is an alternative to.
Yeah, great.
Yeah, now that I know what you two look like and I, you know, I do know your girls from before, I can try to hook you up with that doctor when I see her tomorrow.
Do you happen to know, I know it's specific, but if Davis does research also in that specific?
I mean, they are a research center. They do a lot of research on
Yeah, I know
autism,
they do in
right?
other areas.
But on NBIA.
I don't know specifically about
Okay, I'll look into
PLAN.
it, yeah.
Yeah. Okay. Fragile X, that's the other big thing they do.
Do you all have Facebook?
Yeah.
I think it would be really good for us to all be in touch. I mean, since we now know each other, if there's anything, something like that, or hey, we had this come up. Did any of you struggle with that?
We're happy to share our numbers too.
You guys need a group chat.
In addition to.
Yeah.
Because I've been always in like those big groups, but you kind of get someone else.
Yeah,
Like,
absolutely.
Like if you know where you're seeing them face to face, like you met, it's a big nicer.
All right. I think we can wrap up the official part of this and you all can continue chatting and whatever you're going to do.
Good to meet you all. See you all.